When a cell is exposed to physiological or pathological stress, its survival comes down to a single factor: the severity of that stress. Depending on the load, the cell will either adapt, sustain injury, or die. A normal cell exposed to stress branches into several distinct paths. If it can handle the load, it achieves a new steady state through adaptation. If the stress exceeds its limits, it suffers cell injury, which can progress to irreversible cell death, apoptosis or necrosis. Looking closely at the adaptation branch, we see the cell's attempt to survive despite a hostile environment. In clinical pathology, recognizing exactly which stage a cell occupies on this timeline is how you distinguish a benign physiological response from impending organ failure. This diagram outlines the two primary ways tissues grow. On the top, hypertrophy shows individual cells increasing in size by packing in more organelles. Below it, hyperplasia shows an increase in the actual number of cells, driven by mitosis. On the right, carcinoma in situ involves the entire thickness of the epithelium, but the basement membrane underneath remains intact. On the left, the cells finally breach that membrane to become invasive carcinoma. As long as that basement membrane holds, the condition is pre-invasive. The exact moment those cells cross the line dictates whether a patient needs a local excision or systemic chemotherapy. When stress entirely overwhelms a cell's adaptive capacity, it enters a state of injury. The most common cause is ischemia, which starves the cell of oxygen. Without oxygen, ATP production plummets, causing the cell's sodium-potassium pumps to fail. Sodium rushes in, and water follows right behind it. In this diagram, water influx causes reversible cellular swelling. Notice plasma membrane blebs and detaching ribosomes halting protein synthesis. Without blood flow, irreversible injury begins, hallmarked by severe membrane damage. The plasma membrane ruptures. Calcium floods the cell, activating destructive enzymes. The dying nucleus breaks down in 3 stages: pycnosis, shrinking, karyorrhexis, fragmenting, and karyolysis, dissolving. For a pathologist reviewing a biopsy, finding a swollen cell means the tissue is struggling but salvageable. Finding a ruptured membrane and a fragmented nucleus means the tissue is permanently dead. This table highlights the clinical distinction between the two pathways of cell death. Necrosis is an unregulated pathological process that always triggers acute inflammation. Apoptosis is a highly controlled, programmed cellular suicide that cleanly disposes of the cell without causing any inflammation at all. Apoptosis can be triggered from within the cell via DNA damage and p53, or from the outside through death receptors. Either way, both pathways converge to activate executioner caspases, which systematically dismantle the cell's internal structures. Necrosis leaves distinct visual footprints depending on the organ. Ischemia in the heart or kidney preserves the tissue architecture as coagulative necrosis. Pancreatic injury destroys fat through saponification. Tuberculosis creates a distinct cheese-like caseous necrosis inside the lungs. Whenever you see a biopsy flooded with neutrophils and acute inflammation, you are looking at unprogrammed catastrophic tissue murder, not a regulated biological process. This excerpt from question 5 presents a classic vignette. A patient suffers a cerebral infarct, and the dead brain tissue is completely destroyed into a liquid, viscous mass. Brain tissue follows a strict high-yield rule. While ischemia in almost every other solid organ causes coagulative necrosis, ischemia in the brain universally results in liquefactive necrosis, driven by destructive enzymes. We can organize all of these mechanisms into a clear diagnostic matrix. Reversible injury is marked by swelling and detached ribosomes. Irreversible injury requires membrane damage and pycnosis. Apoptosis is driven by caspases with zero inflammation, while necrosis bursts the cell and guarantees an inflammatory response. By memorizing these rigid boundaries, you stop guessing on pathology questions. You can look at any microscopic finding and trace it directly back to the exact cellular mechanism that caused it.